Perfect.
Thanks very much, Laurie. So, Laurie, you're at the Children's Institute, and this is our Department of Psychiatry Tuesday lunchtime lecture meeting. We've been going on Zoom for a few weeks now, and it seems to be going okay. Thank you very, very much, everyone, for joining, and Laurie, you in particular. And Petrus, maybe you can add something from your perspective.
Well, thank you, Dan. And I think we have to thank Dan for saying, guys, in spite of COVID-19, let's try doing something on Zoom. And I think people have really appreciated that gentle push from you. So thank you for setting that up in the department. This is one of the social responsiveness talks in the department. And so we were particularly keen to get somebody working in a very socially responsive context. And so that there are very few sections in our department that does more socially responsive work than our colleagues in the Children's Institute. So we were really, really pleased that Laurie agreed on behalf of the Children's Institute to present to us today. So Laurie and Dan, thank you both very much.
Should I dive right in?
Please.
So today's presentation is going to be focusing on the 14th issue of the South African Child Gauge. And this is an annual publication of the Children's Institute, which is really attempting to track progress towards the realization of children's rights in South Africa, and to support evidence-based policy and programming. And I thought I'd start very briefly at the beginning to talk a little bit about the gauge and the thinking behind the gauge as a communications and advocacy product, before turning my attention to the findings of the 2019 issue. So Benyam Mesmer, who sits on the UN Committee on the Rights of the Child, outlined a threefold purpose for the South African Child Gauge. So the first intent is really to mobilize the resources of the university in order to better understand and address the challenges faced by South Africa's children. Secondly, we aim to make this evidence accessible to those in government who are responsible for both the design and delivery of services for children, so that children's best interests are foregrounded in both policy and program development. And last but not least, we're attempting to support the efforts of civil society and to develop an informed citizenry who are then able to challenge rights violations and to hold government accountable. So you can hear from this description that there's a very strong emphasis on social responsiveness, on social justice, and on equity, and to building the capacity of both professionals and citizens to engage with government and to ensure that children's rights are respected. The second quote comes from Linda Richter from the Center of Excellence in Human Development at the University of Witwatersrand, and she talks about the ways in which the Child Gauge collates and interrogates the latest research evidence from a child-centered and policy perspective. And in the process of seeking to make this research relevant and accessible to both policymakers and practitioners, we start to identify blind spots, knowledge gaps, and areas for further inquiry. So in a sense, this isn't simply an exercise in knowledge translation. It's also a process of active engagement where we bring together both researchers, policymakers, and practitioners to think about how we can improve the conditions and services for children in South Africa. And it's not necessarily a comfortable process or an easy process, but it's certainly necessary, productive, generative, and often transformative. So that's just a brief introduction to the gauge. And the 2019 issue is focused specifically on child and adolescent health. And as you can see from the cover, there's a strong emphasis running throughout on equity and social justice. But we also intentionally chose this photo for the cover because we wanted to disrupt the ways in which we commonly think about child and adolescent health. So we chose a photograph of children outside the healthcare service to signal the ways in which children's care arrangements and living conditions are the primary drivers for child health and development. We also chose a photograph from the sort of remote, more rural setting, where very often we tend to describe children living in these areas as experiencing multiple deprivations. So we, as researchers, come very often with a deficit view, and we wanted to challenge both health professionals and researchers to see children as human beings who are meeting us with energy, with positivity, with a desire for engagement, and to really treat children as active partners in their own health care. Lastly, I want to acknowledge that the Child Gauge is a collaborative effort that brings together, this particular issue brought together over 70 contributors, over 30 reviewers, and was led by a very strong editorial team, including Maylene Shung-King, Michael Hendricks, and David Sanders. And last but not least, I wanted to draw our attention to the sense of urgency that informed the writing and the planning and the conceptualization of this issue of the Gauge. So a real sense that the child cannot wait. But right now is the time that the child's bones are being formed, his blood is being made, his senses are being developed. And to the child, we cannot answer tomorrow. That child's name is today. And just a brief recognition of David's incredible contribution both to this Gauge and to child health and public health in South Africa. As you listen to the presentation, you'll certainly hear his voice in the background with its emphasis on the social determinants of health, on equity, and on community health workers. So the Gauge itself is structured into a series of 11 chapters. The opening chapter outlines the current status of child health and emerging priorities. Then a series of 3 chapters call for a life course approach and the prioritization of interventions both in the first 1,000 days of life and again during adolescence. The following 5 chapters outline pressing and emerging challenges. These include long-term health conditions, violence and injury, mental health, malnutrition, environmental health, and climate change. And the final 2 chapters focus attention on the transformation that needs to take place both within the healthcare system and in building a workforce for child health. So that just gives you a sense of where we're heading over the next sort of 20 to 30 minutes. So I want to start by focusing our attention on children's rights to health. And Section 28 of the South African Constitution guarantees children's right to basic healthcare services. Yet children's right to health is defined far more broadly in international law as the highest attainable standard of health, not just the absence of illness and injury, but a state of complete physical, emotional, and social well-being. And it is this vision of child health that should really guide our attempts to ensure the children not only survive, but thrive. The right to health also extends beyond the right to healthcare services to include equitable access to the social determinants of health, such as children's rights to food, water, and housing. And it lies at the heart of patient-centered care, requiring health professionals to respect children's rights to dignity, privacy, information, and participation in healthcare and decision-making. At the same time, within the South African context, we also need to address children's constitutional rights to basic healthcare services, as this is not subject to progressive realization, and we urgently need to define an essential package of healthcare services so that children and adolescents know which services they are entitled to and are able to claim those services. And this is particularly pressing in the context of NHI, where we're starting to establish baskets of care. And we need to be asking ourselves, within that context, where are the children and where are children's interests represented in a series of advisory committees that will define what goes into each one of those baskets of care. Secondly, we need to recognize that South Africa has made tremendous progress over the last 15 to 20 years in terms of child survival. Yet children continue to die of preventable causes such as diarrhea, pneumonia, and injuries, with neonatal causes now the leading cause of under 5 mortality. Despite this progress, South Africa is performing poorly relative to other middle-income countries, such as Cuba and Brazil. Therefore, efforts to promote the survival of young children need to be intensified, with a particular focus on newborns, who account for around 1/3 of under 5 mortality. While 1 in 31 children die before their 5th birthday, greater attention also needs to be paid to the 30 children who survive, to ensure that they are able to thrive and to reach their full potential. This requires a fundamental reorientation of the healthcare system to address the impact of violence, HIV, and malnutrition, and to promote children's optimal health, nutrition, and development, starting early in the antenatal period. Over the past 10 years, South Africa has made significant improvements in the coverage of key interventions across the continuum of care, from preconception through to adolescence. Yet despite this progress, coverage of key interventions remains suboptimal. For example, immunization is one of the most effective interventions to protect children against potentially life-threatening illnesses such as TB, polio, and measles. Yet only 61% of infants were reported to be fully immunized in the 2016 South African Demographic Health Survey, with rates varying significantly between provinces from 90% in Mpumalanga to 69% in the Eastern Cape. Coverage of care also fluctuates across the continuum. While 94% of pregnant women attend 1 antenatal visit, only 67% received antenatal care in those critical first 20 weeks of the pregnancy. Similarly, while 87% of mothers initiate breastfeeding, only 32% of babies are exclusively breastfed in the first 6 months. And greater access to contraception is needed if we wish to reduce teen pregnancies and improve the life chances of the next generation of children. Similarly, while we have seen a significant decline in the mother-to-child transmission of HIV and in new infections amongst children under the age of 15, there has been little change in HIV prevalence in pregnant women, raising concerns about the growing proportion of children who are uninfected yet HIV exposed. Greater investment is therefore needed in prevention programs to address the drivers of HIV infection among young women and adolescent girls, as young people 15 to 24 years old account for over a third of all new infections, and young women are 3 times more likely to become infected than young men. Yet health sector investments accounted for only half the reduction in under 5 mortality between 1990 and 2010. The remaining gains were driven by investments in other sectors, such as improved education, access to clean water, and reductions in poverty and income inequality. So how are we doing in South Africa? Over the past 10 years, we have made significant progress in reducing child poverty and improving access to services. Yet there has been little change in the percentage of young people not in employment, education and training, little change in those living in informal housing, and 1 in 4 children are still not living with their mothers, most living with their grandmothers, and this points to the ways in which families and women in particular are struggling to balance the care of children with the need to seek employment. And it's certainly one of the critical indicators that we need to be paying attention to in the context of COVID-19. We know that poverty intrudes into every area of children's lives and compromises their health care, nutritional status, education, and access to services. Nearly 60% of children in South Africa live below the poverty line. 30% do not have access to safe water on site, and 18% of children live in overcrowded households. So it is not surprising that diarrhea and respiratory tract infections are key drivers of under 5 mortality. These problems are compounded by poor access to healthcare services, with 1 in 5 children traveling far, more than half an hour, to reach healthcare. 27% of children are stunted, a sign of chronic malnutrition that undermines their health, cognitive development, education, and employment prospects. Nearly half of children have experienced some form of violence or maltreatment. 17% of children in the Western Cape have a diagnosable mental health condition. And therefore, it's not surprising, perhaps, by the time that children are ready to enter the workforce, or young people are ready to enter the workforce, that 30% of youth are not in employment, education, or training. So there's a sense that children in South Africa in many ways are being set up for failure, and that this pattern of poverty and deprivation is then reproduced across the life course. I also wanted to share this slide from the United Nations Development Programme, which starts to highlight who is most likely to get left behind. Children who are poor, children in rural areas or informal settlements who have poorer access to services and economic opportunities, children who experience discrimination, such as those with disability.
Laurie?
I think we've lost your sound.
Laurie, seem to have lost a bit of sound. I'm not sure why. Can still see your slides, but can't really hear you.
Let's hope we can get her back soon.
I wonder if anyone has her phone number.
I don't, but we can maybe, if there's somebody on the call who is a chum of Laurie's, that would be great, just to check with her.
There are a couple of people from Children's Institute who may be able to get hold of her.
Hello, I'll try and get hold of Laurie.
Great, thanks.
Wonderful.
Okay.
It all went very well so far.
Just unmuted everyone just to see if that works. Laurie, can you hear us? Okay.
Maybe the rest of us can just remute ourselves. Because I now hear babies.
Okay, it looks like Laurie is trying to dial in again.
Okay.
The internet got turned off in a bid to improve the connections. I'd just like to apologize to everyone for going silent.
No worries, please continue. You've still got your crowd.
Okay, fantastic. Let me just get the presentation loaded up again. Okay, can you let me know what I said before I went silent, where I was?
I think you were around here, so it was
okay.
Just a second ago, yeah.
Okay, fantastic. Let me regather my thoughts then. Okay. So what we know is that despite being sort of more than 20 years into a democratic South Africa, that these patterns, these intergenerational patterns of inequality are very difficult to shift. And as a result, children living in what were the former homeland areas continue to experience the highest levels of deprivation. And that's across a range of different indicators, from access to healthcare and education to living conditions and care arrangements. So one of the strongest arguments that this issue of the gauge is making is that child health matters. Not only for children today, but because it sets the trajectory for health and development across the life course. For example, infants starved of nutrients in utero are more likely to become overweight as adults and to develop a range of non-communicable diseases such as hypertension, kidney disease, and diabetes. In addition, an estimated 70% of preventable deaths from adult NCDs have been linked to risks encountered and behaviors that started during adolescence. Environmental exposures, stresses, diet and lifestyle can induce epigenetic changes, literally turning the genes on and off in ways that may result in permanent damage. For example, a woman smoking during pregnancy induces epigenetic changes in her daughter and her daughter's reproductive cells, which may predispose both the daughter and the granddaughter to obesity. In other words, children's early environments can have a profound impact on their lifelong health and development, literally getting under the skin and becoming embedded in their developing bodies, brains, and even their genes. It is therefore vital to intervene early, starting in the first 1,000 days of life and continuing into adolescence, as this is when the developing body and brain are most sensitive to environmental cues, and investments are likely to yield the highest returns. Chapter 3 of the Gauge focuses on the first 1,000 days of life, from conception through to the time when a child turns 2. And it draws on the nurturing care framework, which describes 5 key elements that children need to thrive in those first 1,000 days of life. This includes good health, adequate nutrition, protection from harm, opportunities to learn, and caregivers who are attuned to and responsive to children's needs. It examines recent progress, drawing on the ECD Countdown to 2030 country profile, and it showcases how the Department of Health is playing an expanded role in early childhood development and emphasizing the need to build stronger, more supportive relationships with the parents and caregivers of young children through the side-by-side campaign. Chapter 4 turns its attention to adolescence as a second critical point for intervention and highlights key risk factors from poverty and violence to teen pregnancy and school dropout, highlighting how investments in social protection such as cash, care, and skills development can help to build resilience in young people. Parenting support, cash transfers, and safe schools are also associated with significant reductions in violence and improvements in health. And yet the chapter also indicates that when we combine all 3 interventions, this will yield significantly higher returns. Chapter 5 focuses on children with long-term health conditions, and this is an essential part of the shift from a focus on survival to a thrive agenda. And while many of these children have highly specialized needs, all are in need of routine care. And this should ideally be available at all levels of the healthcare system, from communities and schools through to tertiary hospitals. The red arrows in the diagram represent the need for strong referral systems, outreach services, and effective communication and coordination in order to ensure continuity of care as close to home as possible. NHI provides an opportunity to strengthen screening, early intervention, rehabilitation services, and palliative care, but only if the needs of children with long-term health conditions are explicitly addressed in the proposed baskets of care and in the re-engineering of primary health care. Chapter 5 turns its attention to violence against children and violence and injuries. And traditionally, these have been seen as discrete areas of inquiry. Yet this chapter emphasizes the common ground, the ways that both injuries and violence share common risk factors, and the need to develop interventions that adopt an integrated approach. For example, the Walking Bus project, where community members accompany children on their walk to and from school, is helping to prevent both violence and road traffic injuries. Equally important, health professionals need to be interrogating and establishing whether the injuries they see are intentional or unintentional, and to consider and ask questions about the circumstances in which these injuries occurred in order to prevent either further injury or violence. So a real call for health professionals to be looking deeper at the children they see in front of them, to consider the context in which children live, and equally important to invest in therapeutic care so that children are able to not only heal from the physical scars of violence and injury, but are also better able to cope with the fear and trauma. The chapter also draws attention to the Constitutional Court case in 2019, which concluded that corporal punishment is a violation of children's rights to dignity, equality, and freedom from violence. And the chapter goes on to introduce a positive parenting program, which has the potential to reduce the incidence of both intentional and unintentional injuries. The following chapter focuses attention on child and adolescent mental health, based on the recognition that 50% of all mental health conditions are established by the age of 14. Whilst we're looking at a global prevalence of between 10 and 20% of children, we have no national prevalence data in South Africa. So we have no idea of what burden children and adolescents are carrying in terms of mental health. The only data that we do have comes from the Western Cape. It dates back to 2006, when 17% of children had a diagnosable mental disorder. And yet it's particularly concerning that we don't have the answers to this question, given the very high prevalence of child poverty, food insecurity, and violence against children. Even if we're looking at only a 17% prevalence, children account for only 7% of mental health inpatient admissions in South Africa and 6% of outpatient visits. And only 3 provinces have a public sector child psychiatrist. So there's a real sense that children are again being shortchanged in terms of healthcare service delivery. Yet the chapter itself argues that improving child and adolescent mental health requires early and sustained investment that extends beyond mental health services or psychosocial programs into schools, communities, the economy, and beyond. For example, efforts to delay a first pregnancy and to prevent antenatal depression and or low birth weight should enable more children to achieve their developmental potential, and if supplemented by investments in quality ECD programs and schooling, should help to reduce school dropout, violence, and substance abuse in adolescents, in this way driving a positive cycle of physical and mental health. The following chapter focuses on South Africa's burden of malnutrition, noting the persistently high levels of child stunting, affecting 1 in 4 children, the rise in overweight and obesity, which at 13% is twice the global average and is helping to drive this adult burden of NCDs. And also the invisible or hidden form of hunger and the ways in which micronutrient deficiencies are compromising children's immunity and cognitive development. And the chapter, in a sense, again, extends our view, our narrow health-centered view, beyond the proximal determinants of infant and child nutrition. So looking beyond maternal nutrition, exclusive breastfeeding, and complementary feeding, the chapter really interrogates the role of the broader food system in shaping both the local food environment and individual food choices. And it highlights how the marketing of unhealthy foods and the ways in which obesogenic foods are penetrating deep into our informal settlements and rural areas are making it harder and harder for families to adopt healthy choices that are also affordable. The chapter issues a really strong call for the state to regulate the marketing of unhealthy foods, both through legislation and taxation, and to promote healthy food choices in its schools and in its public health institutions. So thinking more critically about what we sell in our canteens, our tuck shops, and our vending machines. Chapter 9 focuses on environmental health and climate change as emerging threats to children, including air pollution, inadequate water and sanitation, chemicals and pesticides, and how these effects are being escalated and intensified through climate change. It recognizes that children are particularly vulnerable to harmful environmental exposures as their central nervous, immune, reproductive, and digestive systems are still developing, and how these exposures are associated with birth defects, respiratory infections, diarrhea, developmental problems, cardiovascular disease, and cancers. And these problems are likely to worsen with climate change. For example, increasing temperatures and heat are fueling increasing levels of violence. It is therefore essential to integrate and explicitly address children's environmental health in policies across a range of different sectors to limit environmental exposures to pollution in settings such as agriculture, transport, housing, and industry, sectors that are not traditionally associated with children or child health. So we need to be asking, where are the children? Are children's best interests being actively considered in a range of critical laws and policies that should be safeguarding their health and best interests? For example, there has been a shelving and withdrawal of legislation such as the Alcohol Marketing Control Bill and the Chemical Management Bill, which was intended to promote child-safe products. Similarly, the National Sanitation Policy fails to recognize or address the extreme vulnerability of children in disaster settings. And there are no child-sensitive measures in the draft National Climate Change and Adaptation Strategy. It is essential that we recognize and uphold children's rights to know the dangers associated with environmental exposures and climate change, to protect their right to an environment that is not harmful to health, and their right to protection from harmful business practices. And this is essential not only to safeguard the health of children today, but also the rights of future generations. Last but not least, it's also essential to recognize children's right to participate in these discussions, in policy development, and the incredibly proactive role that children have played in tackling climate change. So in many ways, we need to shift our perception of children. So children should no longer be seen simply as passive objects, but rather as active participants, rights holders, and visionaries in the battle against climate change, where it is in fact up to us to listen, to respect, to facilitate, and to follow their lead. The final two chapters of the Gauge focus on putting children and adolescents at the heart of the healthcare system. And this really requires a fundamental transformation in the ways in which we deliver services. And these efforts need to begin really early, even preconception, if we are to address the upstream determinants of child health. For example, this photograph comes from the Limb Care program in Limpopo, which aims to reduce neonatal mortality. But it is doing so through focusing on improving the quality of care for women at antenatal clinics and during labour. And I don't think there's a woman among us who wouldn't wish to have someone like Joy Summerton massaging our feet and looking deep into our eyes as we are in the midst of labour. It really does speak to a fundamental transformation of healthcare services, which is putting the patient at centre stage. And if they can do this in the furthest reaches of Limpopo, then indeed we can do it here in the Western Cape. So what does it mean to put children at the heart of the healthcare system? At the centre of this circle is a need for child and family-friendly care that embraces communication, care, and collaboration. This needs to be supported by a child and family-centred workforce and child and adolescent-friendly services that are supported by norms and standards, child-friendly infrastructure, equipment, medicines, and staff. This child-centred or family-centred approach then needs to be embedded within the district healthcare system, with strong leadership provided by the district clinical specialist teams and really strong referral systems to ensure that comprehensive continuity of care is brought as close to home as possible. There's also a need for intersectoral collaboration, again at the local level. So calling on DCSTs to activate networks, to build relationships with local providers working in order to address the social determinants of child health within their particular district and in response to their particular burden of disease. To do this effectively, we need child-centered data. We need to disaggregate data to make children visible, but also to make visible inequalities in order to better target support, identify those left furthest behind, and to track progress over time. We also need to ensure that child health is adequately addressed in all policies, not just health policies, education policies, and social development, but also those that impact on the environment and trade and industry. If one wants to think, for example, of the parental leave policy, which now enables men to spend time with their young children and helps to foster those psychological bonds that are so fundamental in building a strong foundation. And we need to ensure that children's rights inform the design and delivery of all those services with a strong focus on dignity, equality, justice, and children's participation. And through this process, we should be able to progress towards the vision outlined in the Sustainable Development Goals and or use the Sustainable Development Goals to push for and to advocate for changes in the ways in which we deliver services for children in South Africa. And in this way, in this child-centered, family-centered approach to health care, we should begin to leave no one behind. So I just wanted to end with this slide from the Palani Maternal Child Health and Nutrition Program, and just to reiterate the central and fundamental role that community health workers are playing across the country in bridging some of those gaps, in enabling services to be delivered close to home, and how important this outreach is and will be as we move through the COVID-19 pandemic and the recession to follow. So I think I'll end it there and look forward to your comments and questions.
Great, thank you so much, Laurie. That was comprehensive and very passionate. And I assume that we can download this all from the internet, is that correct?
Yes. You can access copies of the book on the Children's Institute website. So that's www.ci.uct.ac.za. And the book is also accompanied with a poster that focuses in on those critical elements of a child and adolescent-centered healthcare system.
Okay, great. So let's open for questions. People can either unmute or use the chat box.
Can I maybe start, Dan?
Sure.
Laurie, thank you. You all already know that I think you have the most beautiful visuals in your report and in your slides, and I think it just emphasizes how powerful it is for us to be able to represent our information in good visual ways. So I think that's a lesson for all of us. So that's just a congratulations. My question to you is this. You commented on the importance of child-centered data. And I noticed that in some of your earlier slides, you showed some data for under 15-year-olds, and then you showed 15 to 24-year-old data. Now, as you might know, Stella Mokitimi in my team is currently trying to do a situational analysis of mental health services for children in the province. And we found it incredibly difficult to identify disaggregated data that we could really talk about under 18-year-olds versus over 18-year-olds. Is that something, have you found it hard, or do you think our information systems are set up to be able to make that under 18, over 18, i.e. child-in-law versus adult-in-law differentiations?
I don't think our data systems, particularly within health, are child-centered in that way. So one is working very often with approximations, particularly when you're looking at that sort of 15 to 24-year-old age band. And the chapter on adolescent health is actually quite interesting because it addresses some of those concerns. How do we define at what point children actually transition from childhood into adulthood? Is it when they turn 18? Is it when they have a child of their own or set up an independent household? Is it when they manage to find employment? And we know that there's this incredible delay between sexual maturity on the one hand and economic independence on the other. So I suppose I'm saying two things. One is, yes, it's tricky to find child-centered data, and a recognition that childhood extends beyond the under fives, all the way through to adolescence. So I think that is one of the important points that this gauge is making, is that we need to have a long-term view. We need to be thinking about what kind of outcomes we hope to achieve for children when they make that transition to adulthood. So again, thinking much more broadly about child health. And there's a fantastic tool in the first chapter called the Adolescent Tracker that is starting to unpack what some of those indicators might be if we're taking an adolescent-centered approach. And then an acknowledgement that it's not so easy to draw a clear line in the sand between childhood and adolescence and adulthood.
Great. I don't know if that helps. Thank you. No, great answer. Thank you.
Okay. Any other questions from anyone?
I have a question.
Go for it.
Hi, Laurie. Thank you so much. It was extremely insightful. I don't know if I'm sort of taking it a little bit too far out, but what is the ideas or ideologies around the most vulnerable, for example, abandoned or orphan children, because of the rate of HIV and all of these things? Those that are abandoned and orphaned end up being the most marginalized, especially when you are already in a system that cannot provide you with care, protection, and your basic needs. And then obviously now needing and depending on government resources completely without familial support. So I know you've mentioned a few statistics, but I was just curious if anything came up regarding, you know, the marginalized that are really pre-marginalized just by birth. Thank you.
I think the good news, to date is that we have been seeing a decline in orphaning rates, and that's due to the decline in HIV deaths. The other piece of good news is that most of those orphans are living with extended family. So they're not necessarily living in foster care. If we're looking at, say, 1 in 5 children who have been orphaned, so either the mother or father has died, only 0.5% of children are actually living in child-headed households. So there is, to date, South African families have managed to hold those children and to provide them with care and support. What that means in terms of COVID-19, with, again, 1 in 5 children living in the care of relatives with neither mother or father in the home, there is a concern that there is a significant proportion of children living with elderly relatives who are particularly vulnerable to COVID-19. So there's questions around how do we ensure the care and protection of those children? How do we strengthen alternative care provisions? So I think the kind of questions you're asking around vulnerability, and that's vulnerability in terms of care, but also vulnerability in terms of poverty and violence. We really need to be factoring those into our COVID-19 response. So we know that children are not likely to die in significant numbers from COVID-19 itself, but they may well die as healthcare resources are diverted from pediatric services to adult care. We're seeing already a rise in hunger, where children are acutely vulnerable. We're seeing a rise in gender-based violence, and we know that the households that experience high levels of domestic violence are the same households where you see high levels of abuse and neglect. So again, children vulnerable from a protection perspective. So we really need strong advocates working in pediatrics, but also in child psychiatry, to be thinking through the implications of this for children and defining a child-centered healthcare response.
Great, thank you very much. I think we've got maybe space for just one last question, so I'm just looking to see who would like to go. no one else does, then I suppose, Laurie, one question I have is in many ways, I think, for this audience, these are messages we would agree with fully. And I'm wondering about your experience with audiences that don't agree or give some sort of resistance, and how you've used the children's gauge or your other work to overcome, to make specific progress. So I wonder if you can talk to that for a moment.
So with the child gauge, or the work of the Children's Institute, we work in different ways with government. At times we work collaboratively and collegially, offering technical support. At other times we partner with civil society to challenge government policies, and doing quite a lot of challenging around the and advocacy and pushing for an increase in the child support grant as part of the COVID-19 response. So the sort of advocacy effort encompasses all those different forms of engagement, from lobbying in Parliament through to the drafting of policy briefs, opinion editorials, petitions, campaigns, and what the gauge does is it provides a common evidence base that can be drawn on by a whole range of actors who inform and shape policy developments.
Great, that's very helpful. So again, on behalf of the department, thank you so much, Laurie. And I agree with Petrus; those are fantastic slides and data for advocacy use. So hope people go and download them and use them. And thanks very much, as Petrus says, to the social responsibility team for putting this together. Thank you so much. Take care.
It's a pleasure.